up. So let's get started here because I want to make sure we stay somewhat on time. So welcome everybody. I'm Neil from the TA Center, and we're going to have in this session a little overview of the basics of infant and early childhood mental health consultation, and then you're going to hear from two states. You're going to hear from Michigan and California about how they've gone about this in their systems, and you see sort of our folks here from those states, and I would encourage you to really be listening for what is it that sort of strikes me about what I could be doing. We tried that, it didn't work, all those kinds of things in your state. We're going to start with California. California's going to focus on funding, and then Michigan's going to really focus on fidelity and data collection, while also giving overviews of how they've gone about doing that. These are two states. I've been doing this work in infant and early childhood mental health consultation for a while now. And these are two states that I would really encourage you to listen carefully. They've really, they've been through ups and downs. They've been through economic downturns. They've continued to move forward, no matter what's sort of happened in those times. And so have always sort of had an eye on the prize. At the end, they're here, available to answer questions. If something comes up, as I said, go ahead and put it in the chat. So I want to start. We're going to have first Khadijah Johnston, who is actually working at Georgetown University Center for Child and Human Development as part of her work. That is in no way all that she does, but Khadijah's with us, and she's going to provide us an introduction to what infant and early childhood mental health consultation is. And I've known Khadijah. I actually learned about mental health consultation from Khadijah. So Khadijah is a clinical social worker. She's been a practitioner in the field of infant and early childhood mental health since 1985, started very young. Past director of the infant parent program at the University of California, San Francisco. So really knows the California work inside and out. And she really pioneered approaches in infant and early childhood mental health consultation. And that's really the model. And quite frankly, we always say Khadijah's written the book because Khadijah's written the book. There's a book on how do you do mental health consultation by Khadijah Johnston. So this is a shameless plug for Khadijah, but I'm going to give Khadijah her 20 minutes to sort of take us through all this. So Khadijah, take it away, please.
Yeah, thank you, Neil. It will be very brief, but my charge today is to give us an overview of what mental health, early childhood mental health consultation is, a little bit about how it works, and to close my 20 minutes with some of what we are seeing are the benefits of early childhood mental health consultation, and really giving this introduction as a means of laying a foundation for the subsequent speakers who, as Neil said, will offer state examples. So wanting to begin with a definition of early childhood mental health consultation as a multi-level mental health service that spans the care continuum from promotion to prevention to intervention. It's an indirect service, meaning not working directly with children as one would in treatment, but an indirect service that pairs a mental health professional with other providers who care for, and like in early education, or otherwise offer services to young children and their families. We see this as a capacity building endeavor, meaning building the capacity of those who care for and serve young children, with an aim at increasing social and emotional awareness and knowledge, and enhancing reflective confidence and competence in the adults that support young children. By collaborating with the primary people in young children's lives, mental health consultation supports, or where needed, really strengthens teaching practices, thereby promoting, we hope, optimal development for all children in a setting or service system. And while we see this effort as aimed at preserving the social and emotional well-being and relational health of all the involved constituents in an early care and education or other program, including the adults, but also in addition to this promotion level, early childhood mental health consultation simultaneously serves as a prevention and intervention function for those children who are at risk for or exhibiting mental health difficulties. Early childhood mental health consultation in the last several years has really burgeoned. These statistics may not even be accurate anymore. More than half the states in our nation say that they have some services, some mental health consultation services occurring, at least in pockets. And 13, and again, probably growing, have statewide efforts. And this intervention began, and the expansion is occurring most extensively in the settings that you all represent, early care and education settings. But it is increasingly being implemented in the range of systems and settings that serve families prenatally and with children through 8 years of age, including child welfare and primary care and domestic violence and homeless shelters and home visiting. So why? What accounts for the beneficial impact that we're seeing, and it's causing this kind of explosion in infant and early childhood mental health consultation? Part, I think, of the power comes from early childhood mental health consultation, as I said, spanning from the promotion, prevention to intervention. While tending to the difficulties of an individual child is really an important part of early childhood mental health consultation, decades of practice for some of us and more recent research confirms the benefit of a kind of upstream approach, that early childhood mental health consultation can promote the mental health of all children in a setting, and that by aiming the work at the teachers and the broader setting, early childhood mental health is building capacity that not only is preventative, but because it's internalized, it actually serves children not only currently in an early care and education site, but also those in the future. So if this is aimed at capacity building for teachers, we then have to ask ourselves, what do teachers need? What do caregivers need? And what does it take to build internal capacity? And while mental health consultation provides information, it gives advice and knowledge, it's, I think, important to acknowledge that knowledge is not, it only is part of what it takes for any of us to make internal change in our practice. Really, early childhood mental health consultation pays a lot of attention to promoting provider well-being. Why? Because how the adults in children's lives feel about themselves has a great impact in how they can show up with the children in their charge. And this isn't just true of those of us as parents, but also as providers. And so promoting provider well-being and addressing stress in a very stressful job of providing early care and education is an important focus of early childhood mental health consultation. We know that caring for a group of young children is extremely stressful. And of course, that pressure has doubled, if not more, during the pandemic. But whether because of stress caused by COVID or tensions that preceded it, those in the early care and education profession have always had among the highest rates of both physical and mental health concerns, even compared to others in the same income bracket. And we also know that teachers who report greater depression and job stress tend to report greater levels of problems with the children who they care for, and that they are more likely to ask those children who they experience as challenging to be suspended or expelled. So conversely, we need to think about, and what we know is that teachers who participate, who collaborate with an early childhood mental health consultant, they describe decreased stress and are less likely to rely on expulsion or suspension or harsh discipline as a way of remedying that concern. Also, early childhood mental health consultation is being shown to boost teachers' sense of efficacy. And what is efficacy? Efficacy is the idea I can make something happen. So teachers need to feel like they're having an impact on the children in their charge, as that I think is a precursor to any of us changing our perspective and therefore eventually our behaviors toward children. So early childhood mental health consultation focuses also on enhanced teacher efficacy. And research is really confirming that the quality of the relationship that the mental health consultant creates with her consultees is really the most powerful instrument of change. How do we diminish a sense of stress and increase efficacy so that there's fertile ground to take in our advice and knowledge and suggestions? And very recent studies have found that the quality of the mental health consultant staff relationship is the single most salient predictor of perceived efficacy, of teachers saying, I think mental health consultation services work, and changing perceptions of children. It's also true that the frequency, how often a mental health consultant and how consistent a mental health consultant's presence is with the teachers has an even more salutary effect. And what we've also are beginning to learn that this positive consultant-consultee relationship is especially impactful when the child who is the focus of consultation is a child of color. Effective mental health consultation in those studies that I just mentioned, where it's of benefit and where we see that the relationship is important, hinges on the quality and the characteristics, obviously. Who is providing the mental health consultation? Who's providing these services? And so far in our studies, the best service outcomes are associated with consultants who possess a master's degree or higher in a mental health discipline, that have at least 2 years of experience working in their discipline, and have training and ongoing reflective support specific to early childhood mental health, equity, and consultation. Training in cultural sensitivity and equity, and training in consultation. What we've also begun to learn is that cultural congruence, matching, ethnic or racial matching between the mental health consultant and the consultee has been shown to be of particular benefit, especially in addressing the racial disproportionalities of children expelled or suspended. And I want to recognize this is a tall order to find someone with all of these characteristics, and yet I think worth acknowledging and striving for. So then let's, in the last half, turn to what do mental health consultants do? Typically in early care and education, there are 3 types of consultation. They're often referred to as programmatic, classroom, and child or family focused. And the first 2 types, programmatic and classroom, these first 2 types are really aimed at supporting, or as I said earlier, where need be, enhancing programs and the providers and the site administrators' ability to engage in relationships, not just with children, but with one another. That adult relationships make a big difference in the quality of care provided to children. So these programmatic and classroom consultation focuses on relationships, adult relationships, and the relationships that providers form with children and families to promote social and emotional health and well-being throughout a program, a school community. And then the third type, child-specific consultation, focuses on concerns about a particular child and addresses factors that contribute to the child's difficulties in functioning well in the setting. And although we talk about these types of consultation as distinct, they're typically provided simultaneously and by one consultant. And regardless of type, we want to look at activities. what are the central activities of a mental health consultant? And I would suggest that the central activity and the crux of change is the meetings the consultant has with the teachers and program administrators. And in the case of child-focused consultation, also the meetings with the child's caregivers and parents. Predictable and even if periodic, but predictable consultation meetings are essential. These consultative conversations are, of course, informed by another activity, which is the consultant's observations. And we often think of child observations. And when we're talking about child-focused consultation, yes, the observation is with the parent's permission. The observation is of the child. But observations of a child are undertaken not only with permission of the parent, but optimally they're preceded by the consultant having been introduced to the child's parents and with ongoing consultation with the child's parents or caregivers. But observations also of a program to help the consultant begin to get a sense of how he or she might be able to better support those adult relationships and overall programmatic functioning. But we also need to remember that observations are only one avenue of understanding and intervention for the mental health consultant. If developing a complete picture, whether that's of a program, a classroom, or an individual child, really relies on the consultant's ability to first elicit from providers and parents, and then to integrate their more long-standing and important perspective. So it's really combining the consultant's observation with the information she acquires from all participants. And then she adds her own mental health and development expertise. And it's combining these sources of knowledge that then the consultant generates, and this is another activity, and assists teachers and parents in co-creating strategies. And the consultant helps to then translate these mutually held ideas into responsive action. And in instances, these last couple of activities on the slide, in instances where a child's needs exceed the indirect intervention of consultation, then a mental health consultant is well positioned and can assist in securing and acting as a liaison to other appropriate resources. And in conclusion, I really want to briefly offer some of the evidence of the effectiveness of this really comprehensive, multi-level approach to mental health consultation. At the level of child and family, so when there is a child-focused consultation, studies indicate that the presence of a mental health consultant is correlated to, as most of us have heard from Walter Gilliam's studies and others, is correlated to fewer expulsions and suspensions, and accounts for positive shifts in teachers' perceptions of children's challenging behaviors. Again, our colleague Eva Shiver in Arizona found this was especially true in changing misperceptions of children of color, primarily African-American boys. But conversely is obviously equally important. Conversely, the practice of mental health consultation is correlated with gains in pro-social behavior, including teachers feeling that children who are the focus of consultation show more self-control, are able to communicate better, have better coping skills, and interpersonal and play skills. Then at the provider level, where the intervention is aimed at enhancing the provider's capacity. At the provider and program level, we have these outcomes that you see on the slide here. And early childhood mental health consultation has been shown to contribute to improved communication between school staff and between teachers and parents. Other studies suggest that the practice enhances program quality by reducing, as I talked about earlier, staff stress and improving teacher efficacy, enhancing capacities for self-reflection on the part of the teacher, which in turn allows them to be more sensitive and improves their skills in classroom management and in interactions with children and their families. And I hope this very rapid overview gives some sense of the shape and possibilities inherent in mental health consultation services, and really provides a launching pad for my co-presenters to talk about their particular approaches and to give some state examples. Thank you.
Thanks, Khadija. And I just, if this was an ad agency pitch, I feel like you won the account, right? It's hard to encapsulate decades of work and what this is and what we're talking about as a way to sort of help everybody be on the same sort of space as we now hear where 2 states have sort of gone with all that. But I so appreciate it, because for me, it's always a good grounding to remember, here's what the qualifications are, the kinds of outcomes that we think about, that it's an indirect sort of mental health service. So hopefully that got you thinking. And so remember, if you have questions, comments, thoughts, you don't have to wait till the end. You can put them in the chat. You're going to hear next from California, folks in not the whole state. We can only fit one person, but well, 2. Well, and then 3, because I saw Marguerite here. But feel free to put stuff in the chat. We're gonna leave plenty of time there at the end. And again, a reminder, if you could just put your name and where you're from, your state, locality, just so we have a sense of who's here. We'll probably, given that it's a small group, we'll just follow up with every single person and say, hey, did you like it? I mean, offer some TA and things like that. So again, thanks, Khadija. Super great overview. Really helps, I think, set the stage to hear from folks. Jennifer Miller from as you see, from West Ed, but really from California, helping us understand how California's gone about this, is going to spend the next little chunk here talking with us about how one state has gone about this. So I'm going to turn it over to you, Jennifer, to share your slide deck. And you're on mute, Jennifer, so just hold your, make sure you get off mute.
Thanks for that reminder, Neil. I was so focused on.
I like it. I would like the whole thing, but let's just go with you off mute and see if that goes better.
Am I now sharing my screen?
You are. You're perfect. You're go.
Wonderful. Thank you so much. And thanks for the opportunity today to share some of the strategies and approaches that California has taken to build and sustain behavioral and mental health consultation services within our early learning and care system, and specifically how these efforts were expanded and leveraged through our preschool development grant. I want to just quickly set the context for this conversation, specifically around our capacity building within the early learning and care system. There have been several innovative initiatives broadly focused on infant, family, early childhood mental health across our state, such as SAMHSA Systems of Care projects and Project Launch and Help Me Grow. Our Department of Healthcare Services is leading efforts to change restrictions in eligibility for mental health services under Medicaid. And we have a statewide endorsement system of infant, family, and early childhood mental health for transdisciplinary mental health providers as well as mental health specialists. Our governor has an understanding of and commitment to early infant and early childhood mental health, in addition to appointing a deputy secretary for early childhood development and senior advisor for the implementation of early childhood development initiatives. Governor Newsom established an office of the Surgeon General and named Dr. Nadine Burke-Harris as our first Surgeon General. And her office has launched the ACEs Aware initiative, working across health and human services and education and nonprofit sectors to prevent and address the impact of ACEs and toxic stress. So while my presentation today focuses on one specific piece within one early childhood system in our state, there really is a constellation of interrelated cross-sector activity happening in California. And because the Preschool Development Grant is designed to engage the multiple systems supporting young children birth to 5 and their families, this really helped us leverage and engage the multidisciplinary system of infant and family early childhood mental health services and supports in our state. I also, as Neil prefaced and Khadijah demonstrated, want to acknowledge and call out the really deep, rich history in California of infant early childhood mental health consultation services, grounded in the work at the UCSF Infant Parent Program and Daycare Consultants. Their foundational principles, practices, conceptualization of infant and early childhood mental health consultation, as Khadijah so wonderfully illustrated, continue to shape and inspire the ongoing development of our system in California. We also have multiple local and agency-led infant and early childhood mental health programs providing services across California. So just a shout out to our partners who are delivering behavioral and mental health consultation services, also in the early learning and care space in California. So for today, I'm hoping to be able to share a little bit about our statewide network of behavioral and mental health consultation services, specifically for early learning and care programs and providers, to share how the PDG has allowed us to strategically expand these services, and then a little preview around future planning for capacity building and sustainability of a statewide system for infant and early childhood mental health consultation. So through the lens of behavioral and mental health consultation, the network project that's being featured today, these are the key funding and policy drivers. Our Child Care Development Block Grant federal funding has been funding the Inclusion and Behavior Consultation Network since 2009. That's had been administered up until just a few months ago by our California Department of Education Early Learning and Care Division. The majority of early childhood, early learning and care programs in California are now recently under the administration of our California Department of Social Services, with the exception of California State Preschool. So the new administrator in California for CCDBG funding is now the Department of Social Services. We have our quality count system in California, which is our quality rating, what we call our quality rating and improvement system. And that oversight is shared between our Department of Education, First 5 California, and the Department of Social Services. Our Preschool Development Grant is administered by our California Health and Human Services Agency in partnership with our Department of Education. And then the Master Plan for Early Learning and Care is an initiative of the last couple of years, a directive of our governor to develop a framework to realize the vision for ensuring that all of California's children thrive physically, emotionally, and educationally in their early years. And then more recently, as I'm sure many of you may be aware, the American Rescue Plan Act. And in California, that is really going to help us fund and leverage some of the historic investments that our state has made utilizing federal funding through CCDBG and the PDG. Alrighty, so just a little bit about the CIBC network and the project I'll be referring to today. For over a decade, the California Inclusion and Behavior Consultation Network was funded by the Department of Education Early Learning and Care Division as part of the service delivery support for children with disabilities, including challenging behaviors, under our Child Care Development Fund state plan in the administration of our CCDBG. The statewide network responds to requests for consultation from early learning and care program administrators, teachers, and family child care providers to focus on improving staff capacity to provide high quality responsive early learning environments for all children, including those with or at risk for developmental delays, disabilities, challenging behaviors, and other special needs. As Khadijah described, the consultation focuses on building provider capacity through strength and reflective practice-based approaches, through an observation and action planning process, often focusing on problem-solving approaches, staff communication and teaching, early childhood mental health, developmentally informed trauma practices, relationship building and engagement with community and family resources. And those priorities are determined by and driven by the needs of the staff that are engaged in consultation. Initially, when CIBC was funded by the Department of Education, the project just served those state-funded preschool programs. And in 2016, with a renewed focus on infants and toddlers, we were able to implement a pilot beginning to offer consultation services to family child care programs and really explore what did the delivery of services look like and for those particular needs of family child care providers. At that time, we were also able to take a look at integrating some of the core components of the quality rating and improvement system, particularly around that R and that I, the rating and the improvement, and looking at components of the environmental rating scales, for example, or the class tool, and thinking about were there points of connection between the focus of the consultation and the requirements that some programs may now have, and if they were participating in the quality rating and improvement system, in an effort to help programs have more of an integrated and cohesive understanding of the different types of consultative support or coaching that they might be receiving through Quality Counts California. In 2018, we were able to expand our eligibility for services to include those programs that were participating in their quality counts. And around that time in California too, we had a handful of potential legislation coming down, taking a look more explicitly at preschool suspension and expulsion, and defining further early childhood mental health consultation services. And I mention that because it was important for us as a project and a deliverer of services to really have our eye toward where regulation and law might be headed, to engage in those conversations with policymakers and with stakeholders in terms of an understanding of consultation services, and then also really thinking about positioning our work to be in alignment with any anticipatory regulatory or changes that might be coming. Then in 2020, we were able to expand that family child care pilot to provide services statewide. And due to an increased severity and frequency in fires, we now have a fire season in California. The advent, unfortunately, of mass shootings, we recognized a need to formalize more of an emergency response system with mental health consultants within our network, specifically to be able to operate in a crisis intervention capacity to support early learning and care programs and providers, particularly around times where communities may be experiencing natural disasters and traumatic events. So in summary here, I guess I would just point out, we really tried to keep an eye on our own quality improvement efforts, as well as the shifting mandates and priorities on the broader early childhood landscape, and stay responsive and maintaining coherence and in the flow of those broader early childhood system changes, and help to facilitate that and articulate that integration also for our clients and programs and providers. There's not a lot of time to talk much at all about our model, but just very briefly, again, just to give you a little bit of a sense of the work of the project. As Khadija mentioned, classroom and programmatic consultation have been the focus of the type of consultation operating in the network. Fundamental to our approach to consultation is the utilization of reflective practice and the consultative stance, upholding the centrality of relationships across the parallel process. Consultants in the network are master degreed staff with significant experience working in early learning and care. That contextual context is so important in terms of understanding the dynamics of group care in applying a given expertise or background that consultants as professionals are bringing through their lens. Our consultants may be licensed mental health clinicians. They may also be master degree folks with backgrounds in early intervention, early childhood special education, and early childhood education. Requests for consultation are submitted online through a centralized system. We have an intake call our staff does with a program to better understand their needs and concerns, what they're experiencing is challenging. And then we do a matching of consultants based on expertise. And in times when we're providing consultation services in person, which we hope to be getting back to very soon. We also really consider geography, our preferences. We have consultants across the state, and we really do our best to match programs requesting our services with consultants who live and work in those communities, who have an understanding of their particular resources and supports in terms of being able to make meaningful connections and partnerships for programs in terms of additional resources and supports. All right, so through the preschool development grant, funding for that really provided the opportunity for us to be able to think about extending support and building capacity within the quality rating and improvement system in California for coaches and program administrators to be able to embed reflective practice within the delivery of their coaching and support up to early learning and care programs and providers. Infant and early childhood mental health consultation services were also identified as a priority in the governor's master plan for early learning and care, which I mentioned previously. So as part of this larger vision, California, the preschool development grant just allowed us to think more expansively about the quality rating and improvement system in our state and building in resiliency factors and capacity within that system for professionals and adults and children and families. So our approach has involved 4 cohorts of Quality Counts California coaches and program administrators, 3 cohorts of home visitors, and 1 cohort of tribal early childhood programs that is representative of both program administrators and mental health providers that are working with tribal childcare programs. And really the intent of this approach, again, was to strengthen and align part of our early childhood development system by building cross-system capacity with QCC, tribal childcare, early intervention, home visiting, and to facilitate that coordination and collaboration and recognition that through whatever system professionals may be working with and supporting those that are working with children and families, reflective practice approaches, the use of inquiry-based conversation and a general understanding around trauma and behavior and the experience of ACEs would be beneficial. So what this has looked like are reflective practice training in communities of practice led by a team of infant, family, early childhood mental health specialists and reflective practice mentors who are endorsed in California. Participants in those 8 cohorts that I mentioned previously are receiving 12 hours of training in reflective practice and supervision, and then 10 months of small group cohorts in communities of practice to be able to discuss through a facilitated conversation and thinking about that application of that skill-based learning from their reflective practice training. The last component kind of these concentric experiences is then the connection with consultants from the network to the participants who are engaging in the training series to really to be able to support and foster that ongoing sustainability, facilitate connections and linkages, again, at that local level. The first group of our four cohorts received reflective practice training and are about halfway through their community of practice sessions. And our second group of four cohorts are completing the reflective practice training this month and next, and will then begin their series of 10 community of practice sessions. So a little bit about where we are headed through the ARPA funding that has come to our state. The California Inclusion and Behavior Consultation Network is sunsetting, and we are transforming into the Infant and Early Childhood Mental Health Consultation Network. The thrust here is to be able to provide access to an expanded suite of infant and early childhood mental health consultation resources, services, and professional development for all early learning and care programs and providers statewide. This will include family, friend, and neighbor caregivers, which will be a brand new group of caregivers. We're really interested in continuing to think about what the particular design and delivery of services look like to meet the unique needs and interests of this particular group of caregivers, which we understand may be different than our other home-based care providers like a family child care provider, and certainly those of center-based staff. In addition, state capacity and systems building efforts will include an infant and early childhood mental health consultant training program to build the workforce capacity of qualified personnel who are adequately prepared and supported to deliver infant and early childhood mental health consultation services. It makes me think about Khadijah's slide and those the circle and the squares around who is it that's doing this work? How do we ensure that they're adequately trained and prepared, and then also supported in terms of the ongoing delivery of consultation services. So that work will be statewide in terms of the training program. In terms of our own network work, we'll be expanding the variety and supports of services that are available, and also deepening and extending the model of our direct consultation services, as well as expanding the cultural and linguistic diversity of the consultants in our network, again, for many of the regions that Khadijah mentioned, and also adding some particular specialized support for our BIPOC consultants within the network. We're also really excited to expand our evaluation and data collection efforts, looking at teacher and child level outcomes, including feedback from parents. And we, in the last year or so, have also begun taking a look at our own surveys and forms that are a part of our service delivery model, and looking at more intentionally embedding elements of the consultative stance and consultant competencies as part of our own quality improvement efforts to really ensure fidelity and efficacy around these cornerstones of our consultant competencies in terms of the degree to which that's demonstrated and received by our clients and programs who receive our services, and also the degree to which we're really embedding and implementing elements of the consultative stance. And related to COVID, we've undertaken an examination and kind of thinking about an exploration around what do the elements of the consultative stance look like in a virtual service delivery model. So given that that's where we'll be headed, I, like you, am really eager to listen to our Michigan colleagues to hear more as they share about their experiences with data collection and evaluation. So just to wrap up in closing, I'll say that the PDG has really served as an important vehicle for us to leverage and support the cross-sector and state system capacity efforts in California, and appreciate the opportunity to share a little bit of our California story with you.
Thank you, Jennifer. This is Neil from the PDG B-5 TA Center. And I think if Khadijah's was sort of the, hey, here's a 20-minute explanation of this really complicated service, here's Jennifer telling us an entire journey in 20 minutes that includes the shifting early childhood priorities, how to use ARPA funding, which we wouldn't have talked about, 3 years ago. How do we sort of think about sort of the funding of this, the workforce, all those pieces. I think Jennifer sort of paint a picture of that, anybody who's listening can be thinking about, so where are we in that journey? What have we done? What has worked? What hasn't? And hopefully that'll make for some rich conversation. We're gonna shift here a little bit, and I didn't even need to do anything because Jennifer set it up so nicely with a segue. So, but they pay me, to do this. They wouldn't let John from Tech even say anything, so I have to do it. But so we're gonna hear from folks from Michigan. Mary Ludke and Dr. John Carlson from Michigan are going to sort of walk us through a different model, a different system in which a state has gone about, again, a journey. I've been on Michigan's journey with them for quite some time. So Mary Ludke is the manager for innovative services in mental health, services to children and families division of the Behavioral Health and Developmental Disabilities Administration at the Michigan Department of Health and Human Services. Mary, I don't even know how they put that on a little name tag, and I'm sure I mangled it, but I just know that you work in Michigan, you're at the Department of Health and Human Services, and somebody who is your boss will yell at me because I mangled where you work, and I'll take it out my paycheck. I apologize. And then Dr. John Carlson's a professor in the College of Education at Michigan State University, go Sparty, and he's a health service psychologist with specialized training in school psychology. And so his research and his teaching and his service have really focused on, obviously, using scientific methods around health practices within school age populations, and has been an integral part of this. So obviously we've picked the right people to sit and talk with us a bit about how one state has gone about looking at the data and evaluation fidelity of their system. So I'm going to turn it over to you all for the next 20. And again, if you have questions, put them in the chat. We're going to leave some time here at the end. So Mary and Dr. Carlson, take it away.
Thanks, Neil. And I think we got our introductions done, so we can just go in. I'm going to give you a bit of a little bit of our background here. Michigan, really, our early childhood system partners are strong champions for ensuring our infants and young children's mental health is supported across the settings where they learn and where they grow. That's no doubt in my mind. We have a strong commitment in our state. And PDG has committed their support to maintaining our infant and early childhood mental health consultation services in Michigan. And in addition to our Medicaid, mental health block grant, our CCDF fundings, those are all used to strengthen our statewide infant and early childhood system, including our database and collecting that data to inform and improve our access, the access to services that are grounded in equity. Additionally, our Department of Education is also committed to reducing the impact of high risk factors, including poverty, and providing equitable resources to meet the needs of all students, to ensure that they have access to quality educational activities. Infant and early childhood mental health consultation is this year an approved line item in our state budget, and we're very pleased about that. Like the California team shared, the cross-system support's critical for maintaining our services across the state. And I'm just going to do a brief overview of the work we do, and Dr. Carlson is going to do the deeper dive into our data system. So he gets the 3 Ds, a deeper dive into data. So but we have our journey here. We have a long history of doing infant and early childhood mental health consultation in Michigan. We've made nimble and make those refinements we need to our work based on the most up-to-date information, our data, the science, and feedback from those in doing the work on a day-to-day basis and receiving those services. We began our work in the mid-90s with mental health preservation seed money to explore and address early reports of children under 5 years of age being expelled from childcare, and it's grown over 20 years to implementing an evaluated model with strong outcomes for our children, our providers, and the families. So one of the things I also wanted to make sure you know, as Khadija shared earlier, Michigan's model is grounded in the same core elements that prevention-based, the mental health of professionals supporting adults who care for young children. And I want to share a few of the critical pieces for our system. Central to our approach is our infrastructure. And that surrounding our infant and early childhood mental health, we ensure that we're meeting fidelity, seeking outcomes, and supporting those doing the work to continue to enhance their skills, their capacity, and let us not forget joy in the work we do. This infrastructure is paramount to our success. You know, this infrastructure includes a state-driven commitment to providing regular technical assistance, training, and coaching to supervisors and consultants through monthly and quarterly touch points. We have a state-of-the-art database where our consultants and their supervisors can access all data in real time for improvement and tracking, as well as celebrating their successes in their work. Our contractual requirements for the consultants are that they receive regular reflective supervision monthly to parallel that reflective stance needed for consultation services provided to caregivers. Currently, currently the work we're doing, and our consultants are trained professionals, they're master's prepared infant mental health endorsed professionals with a minimum of 2 to 3 years of mental health family work before they begin providing consultation. In addition to the state TA and reflective supervision, all the consultants are trained and coached in our model curriculum, the required assessment tools, and before they begin their work in the community, they shadow a more seasoned consultant. The core population model, let's see, what we're saying here. Currently, the map shows Michigan. You can always remember where we have our mittens. And we currently cover 18 counties, but with the recent passing of our state budget, we'll be expanding to 5 more additional areas. Our priority population is infant and young children up to age 5, being cared for in licensed childcare, including family and group care and center-based. And I'm pleased that Dr. Carlson is going to be sharing about the what we do next.
Hey, thanks so much, Mary. Appreciate the opportunity to share with you all today the what of our consultation efforts in Michigan, including the importance of data surrounding the what. Michigan's model includes the provision of child-focused and program-focused consultation. Child and family-focused consultation begins with referral to the consultant from an adult caregiver around a specific child's behavioral concern. In our work, we support the child care provider and engage in home visits to align homeschool efforts around behavioral improvement. Over 2,000 infants and toddlers and close to 3,000 preschoolers have been impacted by this work since 2019. The majority of referrals come directly from child care providers. Most child cases that we serve are identified as white. Most are reported to have experienced at least 2 adverse childhood events, with some having experienced as many as 6. Through the data that we collect, we are seeing expulsions drop by 70% in sites receiving child and family focused consultation. Very positive responses we're seeing within our data. We also provide programmatic consultation. Those efforts focus on working with providers to build a healthy social and emotional climate within the program, approaches to nurture the mental health of all children in care, as well as the caregivers' well-being, are utilized and focused within this work. Since 2019, this type of a consultation has impacted over 7,000 children across Michigan, ages 0 to 5. The top reasons captured for this type of referral from providers is to promote the social and emotional functioning of young children, to reduce caregiver stress, to improve adult relationships, and to work on issues such as transitions based on the data we've collected. At the time of exit, we have seen a 72% drop in the number of expulsions within centers receiving this type of programmatic consultation support. Knowing this information, gathering this data helps ultimately to drive the type of training we're doing and the support that's being provided to the consultants. It also supports our ability to share outcomes with state level leaders and funders. Through our partnership with PDG, we've been able to develop a lot of the database features and enhanced data collection capabilities that can live on beyond federal funding. As we worked with MDHHS at MSU to build a statewide data system, we started by identifying the key variables we needed to collect for reporting to funders to inform the work with an eye towards continuous improvement and to ensure our work was leading to the intended outcomes for children, providers, and families. Examples of the types of variables that we identified as being essential to our work included the demographics of teachers, ages and numbers of children served, race and ethnicity, caseload information, fidelity to the model of consultation, paying close attention to those levels, and integrity to the model, and then certainly child and programmatic outcomes. Our work is a collaboration with a local business who does our database development. That work has been set up to ensure access to the website that is simple, and basically the data entry is clear and as efficient as possible for those consultants using the system. We are constantly focused on reducing the data entry burden that consultants face, and always have an eye on how the real-time data can be used by all relevant stakeholders. This image gives you a depiction of the main page of our website, basically our portal into the data that we collect and the trainings and information that SECs use as a part of their work. You can see our system includes 3 main sections: actions, tools, and administration features. In addition to the tools buttons for data collection and data display purposes, consultants primarily use the begin a case and the reports buttons. Administrators primarily use the manage team members and website buttons. And our data evaluation team is primarily using the view export cases button as we look to evaluate that data outside of the system itself. This image provides you a view of our programmatic reports button. You can see the range and diversity of reports that we have made available to those using the system, including consultants, supervisors, state level administrators, and then certainly our data evaluation team. Some of these reports include demographics of those served, expulsion information and changes in expulsion, programmatic needs, and outcome fidelity and satisfaction reports. An example of what one of these reports looks like is presented in this slide. Here we have some pie charts depicting summary information for the specific site, agency in which the consultant or supervisor is logging in. They can compare and contrast their data efficiently and simply with the statewide data that has been collected and entered into the system. Specifically, this one report that we're showing you on this slide shows the demographics of the providers involved, the types of sites being served, and the number of children served in those sites. As you can tell, data is an integral part of the work we are doing in Michigan. We are intently focused on continuous improvement through a database collaborative problem-solving approach. Data summaries are shared in monthly supervision calls. Bright spots and gaps are discussed at state-level quarterly meetings. Consultants and supervisors have the ability to see their data in real time, which is helping them to reinforce their practices and identify areas for improvement. By looking closely at our data and using it regularly, we've noticed places where enhancements or changes need to be made. For example, we've recently added a measure on preschool expulsion risk called the PERM, which is out of Gilliam's research group. We've also added the teacher opinion survey. We have infused the teapot and tippy toes short forms into our data collection processes. And I note that each of these forms, along with a consultation satisfaction questionnaire, are distributed by a survey feature within our website. That feature allows for the forms to be emailed for completion. That approach allows us to log in, or us to log when surveys are sent, to send reminders when they are not completed within a set period of time, and to calculate survey completion rates. As stated earlier, we have adopted a flexible, nimble approach to our evaluation work. As science changes and priorities shift, especially in this time of the pandemic and ongoing racial injustice, our approaches too have been able to shift. This flexibility provides opportunities to continue to deepen our commitment to equity and access, and we are constantly able to focus on that all too important question of what is working for whom and under what conditions, to ultimately keep our focus on positive outcomes for all. I want to note the contributions of Mary McCrane, who's a critical component of this team to this presentation. I thank you for your attention. I provided the address for the website that we use if you'd like to take a peek at what that homepage looks like. Thanks so much.
Well, thanks, Dr. Carlson and Mary. As my 5-year-old says when I give her 2 desserts, right? Like that was, I mean, I hope for many of you, it either makes you feel really good about the work that you're doing. Wow, we've been doing the same sorts of things that California and Michigan are doing, or it's inspiring you to be like, that's what we should be doing. The idea that there's real-time data, that this has sort of shifted over the years, as Jennifer talked about how they've shifted over the years in terms of addressing priorities and funding streams, and Dr. Carlson and Mary talked about this shift. I hope that everyone in there sees your work, your state, where you're at, in whatever developmental phase you're in terms of building up your infant early childhood mental health consultation system. So we've left time here. It's a large crowd, so I've really been trying to sift through everything that's in the chat, but it's a relatively small group. Hopefully you have some questions, because I'll be forced to ask questions, some of which I may know the answers to, but I'll also ask questions. But we really want you to get something from this. This is, if you're reading the things that are coming from Administration for Children and Families, they're talking about mental health consultation. There's ARPA money, billions of dollars out there for mental health consultation. These are the opportunities. So let's, if Khadijah, Jennifer, Mary, and Dr. Carlson are ready, let's see where folks are at. What are your questions, thoughts, comments? You can just call them out. You don't even have to use a chat, because we're a pretty small group.
I'm just going to jump right in because I'm so excited about so many parts of the presentation. So thank you. So hi, everyone. So Christine from Illinois. So I guess I would just start with this tension that I'm experiencing. So the state is committed to expanding program embedded consultants. However, the challenge is, what do we do with the current workforce that is primarily independent consultants? So I don't think we'll ever get to a place where 100% of our consultants are program embedded, but we have to have intermediate points with which we support independent consultants to allow for that flexibility across funding streams. One funder, our State Board of Ed, uses independent consultants exclusively. DHS, Department of Human Services, Child Care, uses program embedded consultants exclusively. So how do you kind of grapple with those kind of infrastructure supports and kind of building or making the case to get us closer to a more aligned vision or integrated mental health consultation system at a state level?
Ding, great way to start with a real easy softball pitch. That's awesome. So who's going to tell Christine the easy way that you just do like that's a great question, right? Like, I love that Illinois is focused in this way. I'm also scrambling to give these guys a minute to put their thoughts together, but that is a great question. How do you sort of see that shift being able to be made? So I don't know who wants to take first try at this.
Well, I'm happy to address one aspect of it.
All right, Khadija.
And Christine, I'm not sure. I want to make sure the definition of independent and embedded, because I think we often use that in different ways. But my assumption is embedded means that, but regardless, what you're talking about from my vernacular is the positioning of the mental health consultant. And one part I think about is making sure that there's an awareness that if one is embedded as opposed to independent, it has meaning to the consultee, which doesn't speak to the large level of alignment. But I think we often overlook that if somebody is embedded, meaning that they are employed by a program, that has particular meaning in terms of how much somebody is able to have the outside perspective that allows one to kind of think equally about all partners and positions within a program. What I do think about in terms of alignment is that one place where I feel like there can be some centrality is in workforce development and training, that people, whether they're independent or internal, might have particular standards and particular opportunities that everybody, regardless of positioning, would be supported to do on, and as others on the panel have said, would be supported not just in the initial training, which provides a particular orientation, but also in an ongoing way, which I think then minimizes some of the differentiation, whether you're internal and all the time, or whether you're maybe external and a little bit less frequent. So alignment through professional development, centrality of centering or centralizing professional development and ongoing training is one way I think see alignment.
Awesome. Thanks, Khadija. Mary or Jennifer, anybody else want to throw in? And it's okay if the answer is no.
Yeah, I think that's consistent with within the network that I talked about. We've, it's been a statewide system, so we've been able to hold our arms around that. But as I said, there are many infant early childhood mental health consultation programs across the state. So we aren't there yet, but as we've been thinking about expanding the notion of a network to a statewide system, coming to some agreements, maybe around some more smaller achievable pieces where we could find alignment or agreement, that would be building blocks for maybe a more robust and integrated network and system, things around workforce competencies, our own shared understanding or definition of what are infant and early childhood mental health consultation services. Are there some core elements to the service delivery model? Maybe not all in terms of who agreement across the board, but are there some few core components that we could agree would be essential and consistent across our program? So I think we were thinking about what might be some smaller, tangible, more doable places where we could find alignment and agreement and use those as building blocks.
Awesome. And I don't mean to exclude, there are folks here from New Hampshire to Florida to Montana to California. You all may have some thoughts for Christine as well. So I don't know if anybody else has any thoughts. Okay, I do have a side hustle as the director of the Center of Excellence for Infant and Early Childhood Mental Health Consultation. So I have one other thought, and then we can see other questions. Christine, one of the things that I think people need to think about is, what are you trying to do? So just to say, I want somebody embedded, why? What is it that you want them to do? So it might make sense because in our Head Start programs, we need people here 40 hours a week to really understand from the community. Maybe that's why you need them. But I always think that if you're trying to do something, I need to know why. Like, so when I think about what California's done or what Michigan's done with that workforce, and the data from Michigan was really helpful to see, they have a reason that that's the workforce, that's what they're doing, because they know what the outcome is that they're doing. So I always like, and Illinois is obviously, you know, pretty far down the line in terms of thinking about where mental health consultation fits in their early childhood system. So to think about embedded, full-time, part-time, non-embedded, all those kinds of things seems to be about to do what, for what outcome, to do child-centered consultation in childcare, to do consultation to the home visiting program from, you know, all those things I think would be the kinds of conversations to have, so that to what Mary and Dr. Carlson laid out, so that you even know what the data is telling you when you actually do those kinds of things. So just a thought from somebody who dabbles in it.
And is there any data points that they have in common that they're collecting data at this point would also help to inform that conversation? Yeah.
So Christine, does that help? At least starting point? Cool.
Yes, and then I was also really intrigued about the data system because we just launched our mental health consultation database for the state. And now the next iteration of that is to kind of implement an activity tracker. So I definitely took a lot of screenshots because I think that is our vision to what Michigan has done, is to kind of generate these robust reports. But again, we have to get all of our state systems on board, even though if they subcontract or contract for consultants, how do we still make the data relevant to them so that we can make the case for increasing this investment? Is it limiting or reducing expulsions? We have a robust law in Illinois for reducing suspensions and expulsions. And to your point, Neil, the why, what is the goal that we're trying to get to? What is it we think consultation will help us address, mediate in the state of Illinois? And I think each funder has a different idea, and to kind of help bring them to the table to figure that out will help us figure out what kind of data we're collecting so that we can make the case or improve infrastructure to align with that vision. So thank you. I don't want to hog the time, but I could talk all day with you.
But I also want to add, Christine, that our database today, and Dr. Carlson can, you know, swear to this, has evolved over time, you know, depending on the needs of different funding sources and also wanting to explore different parts of the consultation. So, you know, the idea that there's a database, it may also have some changes over time. And John, I probably should have let you jump in on that.
No, I think the database that you use has to be nimble and has to be efficient in terms of its ability to be altered. Certainly, we have a lot of changes and newness that comes from our administrators in terms of what do they want to see differently. So yeah, Mary's absolutely right. That has to be nimble and efficient in terms of changing. Neil, you're on mute.
I just like to practice my finger pointing while I talk, and then I say it, but I appreciate that, John. I do think that's the theme though, right? Is about being nimble and flexible and not just sort of following some really shiny dollar funding source, but understanding what you're trying to do. Like Jennifer sort of laid this out nicely, and Khadijah obviously did this in her work, and you guys have done this in Michigan. But to really think carefully about what are we trying to do and how does this fit in? I love seeing launch, PDG, CCDB. I saw so many sort of acronyms about funding sources that have been a part of that journey. So, and Christine, I really I appreciate the question. So I'll let you do follow-ups if no one else has. Wait, Khadijah, you want to say?
Well, I was going to add, because I think also this idea that you bring up, Neil, about what services for whom is sort of where we're at developmentally in the what I think of as the mental health subspecialty of infant and early childhood mental health consultation, is that I think what Jennifer, you said about, like, it behooves us to think about what are the standards of practice and training that what I call transcend territory, regardless of what system, child welfare, early childhood, what funding source, like what would we agree would be the same, no matter who you're serving or how you're serving them. And then one of the elegance of mental health consultation is its flexibility. Because we are a promotion, prevention, and intervention service, we want to be able to be nimble, not only in our data collection, but in our service provision. And so I do think about the ways in which starting to ask the recipients of our colleagues and collaborators in consultation, what do you need right now? And to really think about how we collaboratively make those agreements so that we can then begin to measure what's important to the consultee, not just to our funding sources, and that we adapt our models. And by models, I don't mean, again, those core principles, but I do mean in terms of frequency and duration. We've talked about, like, oh, we have this model of in San Francisco, where I spent most of my time, my friends, I say affectionately call our model the infinity model, because we didn't need to leave. Others, and much of the randomized controlled trial evidence has come from very short-term models. And for me, the good news is, regardless, we have found common points of efficacy, but efficacy around what? Changes around individual children's outcomes as perceived, changes in teachers' attitudes toward children of color, expulsions, long-term change in programmatic practices. So I feel like wanting to think about how do we both stay stable and steady and tethered to our standards of practice, and at the same time have flexibility to be responsive to particular needs.
Yeah. So we have a little bit of time left. I think the next question should be a yes or no question. I'm just joking. So I think that
I don't have any. I don't know how to respond like that.
But no, but it was a great question that I think led to sort of a couple of other strands. And so really appreciate it, Christine.
Yeah, thank you.
Yeah, other questions, comments, thoughts from folks from other places around the country? So I don't know if it's part of it's like you're feeling like, oh, I don't want to ask the question because it's going to show where we're at or things. But one of the things that I think I heard John say, and I know I've heard from others, is we didn't start where we're at now. And I think if people want to run around and talk about what they've done in Michigan or what they've done in California or what they've done in Connecticut, where one of the randomized control states, that they would all tell you the same thing, which is that where they're at now is not any they took a long way to get there. And you could sit with Liz Bissio from Connecticut, or Walter, or folks, Mary McCrane from Michigan, and Mary and John. What you'll hear is we did not start where we're at now, and the funding sources in those places. So I hope that all of you are sitting there thinking about, well, where are we? And whether you are sort of far down the line, you've got relatively secure funding, significant data systems like John laid out, or you're really still like, I don't know, we got like 2 people, I think, doing mental health counseling. You're fine. And I think part of this is to encourage you to start to think about, so what do we do next? It's right. This isn't Squid Game. You don't make a wrong step on a glass pane. Nothing's going to like, you're okay. But maybe figuring out what's the next thing. You didn't think I was going to work a Squid Game reference in, did you, John? That's okay. Every single time I do. So other thoughts, questions, comments, Pamela, people who, presenters? You're on mute, Pamela, if you're talking.
No, Khadija, I really appreciated your comments, and I just put this in the chat, building off what Mary shared about sort of thinking about common components. And I think these pieces on the duration, for example, are going to be really key in figuring out what the common components are. I don't know if other folks who are working on models have any comments about that, but I think, these are the things we're going to be thinking about as we move the field forward, and as people are using diverse funding sources to expand implementation of infant and early childhood mental health. I mean, right now is the time that we're seeing this happen. I also just really like what several folks, and Christine, you've been really helpful in all of our sessions this week, asking great questions. I really like what I've heard about building infrastructure across funding streams and across sectors, and what a great opportunity PDG Birth to 5 has been for being able to do that.
Yeah, so Pamela, that might be a good place for us to stop. We'll put up a couple of housekeeping slides and things like that. I want to thank all of you, Khadija, Jennifer, Mary, Dr. Carlson, Pamela for helping out, John from the tech side, making sure we're moving along. But I want to thank all of you. I think you have an opportunity with your PDG work to sort of leverage something right now that we haven't necessarily always had that opportunity. There was no PDG when Khadija was trying to figure out, well, how do we do this work in San Francisco? Shouldn't just sort of pull things, PDG and ARP and all these other sorts of things. So I hope that you'll see these opportunities. There are clear messages. Certainly the Office of Child Care, ACF, Head Start are talking about mental health consultation in very real ways. One other place we'd like to encourage you to really look for this is in the research connections, right? There's lots of policy relevant research. Some of you may be like, well, how do I get my policy levers moving? And you can sort of browse this by topics. Is another place. Obviously reach out to your TA providers from PDG and talk to one another. Look at who came. It's not like there was 650 people came to mental health sessions this week. It was probably about the same 15, 20 of you. You're all in the same boat, which is you're desperately trying to address mental health and social emotional learning in this PDG context. Try and reach out to one another and say, hey, I kept seeing you. What are you doing? Or why do you keep coming to, because you're obviously trying to figure some of these things out. And Christine, your question, sort of spurred a good discussion. So really appreciate it. Just a reminder that the TA Center is, through the Office of Child Care. There's email. If you have questions, subscribe to those updates. There are great resources that are coming out. In addition to Squid Game, I'm also following PDG B-5 TA Center on Twitter. There are good resources that you sort of get connections to, and they'll sort of cross post things. So lots of good things coming from all the TA centers that are out there. So with that, I want to give you a couple minutes back in your day. Thanks again for all of you for presenting. Thanks to all of you for attending, and hope you got something from the session. So thanks all. Take care.
Thank you. Bye-bye.